This program is a presentation of UCTV for educational and non-commercial use only.
Thank you so much for inviting me, and thank you to all of you for sharing this evening with me. So, why do we bother imaging the breast? We do because of this. Because breast cancer is the leading non-skin cancer in women. It's second only to lung cancer as the leading cause of death in women. And per the American Cancer Society for 2009, about 250,000 women will be diagnosed with breast cancer. 40,000 will die a year. It doesn't affect only women. About 1,900 new cases of breast cancer will be diagnosed in men as well. And actually, more men die from their breast cancer when they're diagnosed than women. Part of that is because they're not screened, right? Okay, so let's talk about breast cancer types. This is my diagram of a breast. There's the nipple there. Those little yellow stringy things are going to be fat lobules. This is a collecting duct. So this whole thing is a ductal unit, and the breast has many ductal units. The ducts are right here, and the terminal ends of them are called lobules. If we look at one of these lobules, this part right here is the duct, okay? And there are cells that line that duct. This whole thing, these little undulations here, are lobules, and the cells in there are the lobular cells. If we look at an individual cell, there's kind of a spectrum of what can happen from that being normal to just growing a lot, growing abnormally, which we call dysplasia, and then growing into abnormal cells that are neoplasms, what we call neoplasia. And there's a spectrum from carcinoma in situ to frank cancer. So the breast cancer types, we're going to start with the ones we call in situ disease, pre-invasive or non-invasive disease. This is when these abnormal cells, these neoplastic cells, are confined to the duct cells, and it does not invade into the tissues around that. Its most common type is ductal carcinoma in situ. You might have heard of the term DCIS. That's what we're talking about. It counts for about 1 out of 5 breast cancers that's diagnosed. Even though it's considered a pre-cancer, a non-invasive cancer, we still lump it in with the cancers because the studies are kind of, there's a wide range, but somewhere between 14 and 77% of these will progress to an invasive cancer. So for the most part, they're treated like a cancer even though they have not yet invaded, okay? The other type is lobular carcinoma in situ, so if it begins in those lobular cells, and that's really not considered a cancer. It's just if you get that diagnosis, if we find that in your breast, you're considered at high risk for developing breast cancer in the future, either in that breast or even in the opposite breast. And that risk is somewhere between 30 and 40% of developing an invasive breast cancer in your lifetime once that diagnosis is made. Now, the main type of breast cancer, when you hear about the breast cancer that kills people, is ductal carcinoma. Okay, and that comprises about 85% of breast cancers. And there's a whole host of different subtypes of ductal carcinoma that are listed here, and they carry different prognoses. Most of these are more specialized types of cells, and these have a more favorable prognosis. Lobular carcinoma can also be invasive, and that accounts for about 10%. Cancer can also start in that connective tissue around the ductal units. The phylloides tumor is one that it doesn't metastasize so much, and most of these are benign, but they grow very fast, they grow very big, and so they still need to come out because they can invade into the chest wall, and so they get wide excision. You can even have cancer develop in the blood vessels in the breast, and those are called angiosarcomas. Now, there's some special types of breast cancers that have received some attention in the media that I want to talk about because you may have heard about them, and one is the triple negative. Has anybody ever heard of that type, triple negative? What that is an invasive ductal cancer that lacks the receptors for estrogen, progesterone, and the HER2 protein. And why this is important is that there are hormonal therapies and drug therapies that if a cancer has those receptors, it can be treated with that. And it has been shown that if your cancer, again, has those receptors and they treat you with that, that you have a lower risk of recurrence. So in these triple negative cancers, they'll grow more quickly, they'll spread more quickly, and unfortunately they affect younger women and more African American women. The other type you might have heard about is the inflammatory cancer. And that was going around on the internet a lot a couple years ago. And this is when the cancer cells block the lymphatics that drain the skin. So it presents like an inflammation. We'll see skin thickening, dimpling. They call it the peau d'orange. It looks like an orange skin, kind of that dimpling. It may look red, warm, tender, just as if there was an infection. But actually, there's cancer cells that are affecting the breast. So that's why it's called inflammatory. It's rare. Thank goodness, it only counts about for less than 1% of breast cancers because there's a very poor prognosis. Most of these are aggressive, and they're diagnosed at advanced stages, typically 3B or 4. So I'm going to talk about the staging of breast cancer. Okay, these are the stages here from 0, which is the non-invasive, right? The DCIS, the pre-invasive disease is called stage 0. Most cancers are graded or staged by this TNN system. That stands for tumor, so the tumor size. N stands for nodal involvement, has it spread to the nodes. And then M is for metastases, as it's spread to distant organs. So all of these are based on the size of the tumor. So if it's small, less than 2 centimeters, and it hasn't gone to the nodes or anywhere yet, it'll be a stage 1. If it gets a little bigger, between 2 and 5, but still hasn't gone to the nodes, it's a 2A. If it has gone to the nodes but stayed on that same side and it's 2 to 5 centimeters, it's a 2B. Or if it's very large, more than 5 centimeters, but hasn't gone to any of the nodes, it's still a 2B. Once it starts affecting the nodes and they're stuck down and kind of really matted, now we're into a 3A. And then if it invades the chest wall, the skin, like the inflammatory cancers, that's a 3B. Once it's gone to the peripheral organs, the liver, the brain, then that's metastatic disease, and that's a stage 4. And staging is important because that's going to predict outcome. These are the 5-year survival rates that were published by the American Cancer Society this past fall. You can see we've done pretty well with the stage 0 and stage 1, 100% survival at 5 years, okay? But as soon as we start affecting the nodes, that survival rate is going to decrease pretty precipitously by the time we get to stage 4. So how do we image the breast? Just like the car industry, we have the big 3, mammography, ultrasound, and MRI. With mammography, we're going to image with X-rays. That's the only one that uses X-rays. Ultrasound, we use sound waves. And MRI, as you might have heard from the earlier lectures, using magnetic fields. So let's start with mammography. This is a picture of a mammogram unit. And this black thing right here is the platform. Okay, the patient comes in, we place the breast on it, so enter breast, and we compress. Now, the reason we compress is we don't like to induce discomfort or pain, but there's several reasons. One, we want to spread out all those tissues so we can see what's going on under there. We want to hold the breast in place because any motion is going to make the picture blurry. And by compressing the breast, we can decrease the amount of radiation that we're giving, okay? The X-rays are generated in this component of the machine right here. They pass through the breast to a screen film, just like you're exposing film in your camera. There's a little slot right here that the screen film goes in. So that slides in there. Then the film gets exposed. They check to see if they're okay, and we get images. For a standard exam, a woman gets 2 images of each breast, and these are the positions. We ask them to change into a gown. They have to wipe off any deodorant because there's some metallic components to deodorant that will cause little white spots on the mammogram. And we compress each breast in these 2 directions. They have to hold their breath during that exam again, or there'll be motion. It takes somewhere between 2 and 6 seconds for one of those images to be obtained, and the whole exam takes somewhere between 15 and 20 minutes if they have to wait for the technologist to go and develop those films. Now, by convention, we call these images by the direction of the X-ray beam. So this one, for instance, where the X-ray beam is coming from the top, cranial, to caudal, we call that the CC projection, cranial caudal. The second projection we take is called a medial lateral oblique, for MLO is the acronym that we stand for that. And the reason that we get this view as opposed to just a true lateral side by side is most breasts have a lot of excess tissue going towards the armpit, going towards the axilla and the axillary tail. And if we went straight up and down, we'd miss some of that. So they found that actually doing this projection instead of a true orthogonal plane is going to get more breast tissue. Now we can do lots of other positions. This would be a true lateral. This is called the cleavage view. That's pretty self-explanatory. And this is the Cleopatra view, and it's supposed to simulate Cleopatra kind of relaxing down the Nile as she's getting that. And I know the first question everybody's gonna ask, so I'll answer that right now. No, this is not comfortable. It's not painful, but it's not comfortable. And this is what the images look like, okay? This is our CC, this is our MLO. Fat is black, it's dark. It travels easier through the tissue, so it's all the dark stuff here. All the white stuff is muscle and breast tissue. You can see the pectoralis right there, okay? Now what about digital? Digital, it's pretty much all the same, but instead of a screen film cassette, we have a digital platform. And inside this platform are these little thin film transistor arrays that are made up of silicon or selenium, and the image is sent over to a monitor. And we view that image at the monitor pretty quickly and within a couple seconds, and so it doesn't require any film to be processed. Now there are some advantages to that. It's a slightly quicker exam, again, because we don't have to process it, look to see if it's okay. It's safe for storage. We don't have to worry about losing the films, and it's very important to compare films from the previous year to see if there's been any change. We can transfer them electronically to different sites to get opinions, and we can do things to the images on the computer when we look at it that we can't do with the screen film. Once you get a screen film, what you have is what you have, but we can do little things on the computer. So I'm going to show you. These are digital mammograms, but they're pre-processed. What happens is there's a reader that comes across, and once it starts seeing something there, it adds pixels, and it adds this gorgeous skin line here, and really accentuates the contrast of what we're seeing in there. And it does that on both sides. So this is what a digital mammogram will look like compared to the analog films that you saw. But probably the main advantage, again, is that we get to sit at a workstation and look at these. We can invert the images, we can make them bigger, we can make them smaller, we can measure and annotate things, and we can change the level and the contrast to really see through dense tissue. But is digital really better? You heard a lot going on, right, with the papers that had come out, and the answer is yes for some women. There is a small group. The DMIS study, the Digital Mammographic Imaging Study Trial, was published in 2005 and said that for women under the age of 50, if they were pre or perimenopausal and had dense breasts, that digital was more sensitive. However, that same group of researchers revised that slightly in 2008 and said, well, you know, when we really looked at the subgroups, they have to have all three. It wasn't just being less than 50 having dense breasts, or you had to have all three. And in that group, they found that screen film was more sensitive, 54%, compared to digital, which was 79%. So let's talk a little bit about terminology here. What do I mean by sensitivity? It's the percent of time a test is positive when disease is present. So if you have 100 women that have breast cancer, and the test picks up all 100 of those breast cancer, that's 100% sensitivity, right? If it picks up 80 out of the 100, that's 80% sensitivity. Specificity, that's if you're normal, you take 100 normal women, and how many times or what percentage of the time does that test call it normal? That's specificity, okay? And positive predictive value, I'm gonna be talking about the PPV a lot with these different modalities. That is, if I recommend a biopsy on 100 women, and 20 of those turn out to be cancer, and 80 of those turn out to be benign, my PPV would be 20%, okay? So the likelihood that it turns out to be cancer when we recommend a biopsy, that's pretty much what we're talking about, all right? Breast density. Why does density play a role, and why is digital better with dense breasts? This is 4 examples of different breasts that have different degrees of breast tissue, the fibroglandular tissue, the ductal tissue relative to the fat. And we're actually required to categorize every single mammogram that we read. We have to give 1 of 4 densities. A 1 is a fatty, and that means that they're less than 25% fibroglandular tissue, primarily composed of fat. We can give it a 2, scattered, so somewhere between 25 and 50% fibroglandular tissue relative to fat. A 3 is heterogeneous, 50 to 75%, and with a grade 4, it's more than 75% dense. Now, why is this important? Because cancer, this little white irregular blob here, is white. And if I project it on this fatty breast, I can see it pretty darn good. I can still see it over there, getting a little harder. If you can see it, you're better than me, okay? So how do you know if you have dense breasts? That's the next question everybody wants to know. How do I know that I have dense breasts or not? The answer is you need a mammogram. This is a mammographic descriptor of how much fibroglandular tissue you have relative to fat. It cannot be judged by the size of the breast, the weight, how it feels, or how much it falls, unfortunately. So what do we look for as radiologists? We look for white areas, if they're focal, if they look different than the other side, if they're in one view or the other, and these are the terms that we use to describe them in the report. We look for things being distorted. It looks like something's pulling together. We look for very bright little white spots. That's what calcifications look like, and I'm going to show you examples. We look for changes in the skin and the nipple. Does the nipple look like it's being retracted? Is there dimpling going on in the skin? And we look for the lymph nodes, because maybe that's a sign that something has spread there. So we look up in that armpit as well. And so now I'm going to show you some examples of what these different things look for. This is a mammographic image. We see this round white area that's fairly well circumscribed, a little lobulated here, and it turned out to be a cyst, okay? But that's what a cyst is going to look like on mammography. This is something, there was something palpable here, and you see this area right over here. I'm going to circle it for you. This almost looks like a breast within a breast. It's something called a hamartoma. It's normal, it's benign, but it has both fatty and fibroglandular tissue in its own little capsule that lives in the breast as well. This patient didn't have anything going on in the breast, but what's going on up here in the axilla? Those were what big lymph nodes look like, and this patient had big lymph nodes because she had HIV. Okay, she had AIDS. These are what vascular calcifications will look like. These are the vessels that are actually calcified. It looks like railroad tracks or tram tracks, okay? There was a time where we were told that maybe we should report those because it might have meant that the patient was at increased risk for cardiovascular disease, but it's not uncommon to see these over the age of 50. We will report on them if the patient is under the age of 50 because that might be significant, again, for an increased risk of cardiovascular disease. This was a 46-year-old woman. And she had so many vascular calcifications, we could see it almost down to the capillaries. She had diabetes, she had end-stage renal disease, she was on dialysis. So that was the reason she had a lot of atherosclerotic disease going on. These are examples of calcifications. These are coarse, chunky calcifications. These are what oil cysts look like. So there's a lot of fat in the breast, right? When the fat liquefies, they can form little cysts, and you can get calcium around it. Calcium's just a mineral, right? This is a fibroadenoma. It looks calcifying almost in a popcorn shape, and we call it a popcorn calcification. And this patient had some trauma. So again, there was necrosis, or some of the fat in there had died, and the body's response to it is to put calcium there, okay? But other calcium isn't so good. DCIS, that's how we see it. That pre-invasive cancer looks like tiny little calcifications, and they're hard to see, so I'm going to magnify this here. You see these little linear branching white spots that look like they're almost in a fan-like distribution coming from the nipple? That's what DCIS looks like, okay? And sometimes it can be very obvious and pretty extensive, and other times it can be a tiny little cluster. I'm going to magnify it there. Just these few little tiny white spots. They look pretty subtle compared to those big other calcifications, right? But those were benign, and these are pre-invasive, all right? This is what an invasive cancer will look like. This big white spot here that has all these irregular margins, kind of spiculated, that's what a cancer looks like. This was a 28-year-old who had something palpable. They put a needle in it. They said it was a fibroadenoma, but they sent her for imaging anyway, and she came to me, and she had this. And it was very irregular. We didn't buy the benign diagnosis. We biopsied again. It was an invasive ductal carcinoma. She was 28. Lobular carcinoma looks a little different than the ductal in that it's typically can only be seen on one view. This is very, very subtle, but over in this breast, you see how things look just a little distorted, almost like a sunburst or a little star where things are kind of being pulled together. That can be all that we see with lobular carcinoma. It's a very difficult diagnosis. Inflammatory cancer, that one I told you that looked like an infection. We see the skin thickening over here. It looks a little bit whiter. The breast tissue looks denser and kind of all coalesced. And then there's a bunch of big lymph nodes up in the axilla. That's what an inflammatory cancer looks like. What about these? Anybody have any idea? Big bags of water. That's what implants look like. These are saline implants, okay? And this is what silicone looks like. These are very dense. You can't see through that silicone. And this woman has actually developed a reaction against her implants, contractures, and these dense fibrous capsular calcifications. She also has a little bit of a rupture right here. This bright silicone is coming out of the implant over there. And some women, unfortunately, not in the United States, but in many Asian countries, they'll inject the silicone straight into the breast. I see way too much of this at the county. They'll inject silicone, paraffin. There's a new gel that they're injecting both in South America and in Asia because it's less expensive, right? It doesn't require surgery. And so you've got a lot of doctors, or maybe even non-doctors, just injecting this stuff in women for augmentation. As you can see, it would make a mammogram very difficult to interpret. It's going to be very hard to see something bad going on in this kind of background. Now, this is a male patient, and sometimes we'll image male patients when they present with pain or a lump. Typically, it's right behind the nipple. And when it has this kind of appearance that we call a flame shape appearance behind the nipple, it's called gynecomastia. It means development of duct tissue in a male that we usually don't see. It can be caused from smoking marijuana. It can be caused from alcohol use. Different types of medications can cause this, and liver disease. Okay, it's because basically they're turning their testosterone into estrogen, is what's happening. So how do we use mammography? We can use it as a screening exam. We can use it as a diagnostic exam, and we can use it to guide us doing procedures. So let's talk about a screening exam. What does that really mean? The goal of any screening exam is to detect early disease before it causes symptoms so it can be treated and cured. And ideally, this test would have a proven reduction in morbidity, meaning it would make less people die from that disease. It would be affordable, so a lot of people can use it, accessible, and could be reproducible, right? We could rely on it. When we talk about screening mammography, therefore, the patient can have no symptoms. When we do a screening mammogram, she has no complaints, the doctor doesn't feel anything on clinical exam, and the only reason she's getting this test is because she's at risk for developing breast cancer, because she's female and because she's of a certain age. And we're going to get into that who and when later, because that's where all the controversy begins, okay? So let's just say, though, for a screening exam, no symptoms, but for women, okay? And it can be interpreted by the radiologist at the time when they're there, or most of the time it's actually more efficient to just batch read them after the patient leaves. So it's unusual to actually get your result right when you're there, though that can happen. Most of the time you'll get a report later with the results, and we'll read those later on. Now, diagnostic mammography, there's a different goal. There's usually some sort of problem or question that needs to be answered. That can either be because the patient feels something, a lump, the doctor feels something when they examine the breast, or we see something on that screening exam that doesn't look quite right. So now we're going to bring you back for a diagnostic mammogram. And in this scenario, you can be any gender. We do men as diagnostic mammograms. We don't do screening mammograms on men, but if they have a problem, we will do a diagnostic mammogram. They can be of any age. There's no minimum or maximum age that we can do a diagnostic, and we do it when they have the symptom. So there's no interval that we do it on. That's only for screening. And the evaluation is completed while the patient is in the department. Whether they need an additional ultrasound or whatever, we have to answer the question while the patient is there, all right, and come up with a final evaluation of what is going on. So what are the things that you're supposed to worry about that are they're suspicious? A lump, feeling something hard, fixed, inside. Focal thickening, if there's just one area that's really, really thick compared to the other sides. Nipple retraction, that's new. Some women have chronically inverted nipples, and that's not a big deal. But if all of a sudden the nipple is retracting inside, then something could be going on in that ductal system. Skin changes, again, that dimpling. If when you raise your arm, you see a little dimple go in, that's not good. Having focal unilateral pain that's there all the time. You have diffuse pain that comes and goes with your cycles, you're a woman, okay? We all have that. But if it's there in one area, you can point with one finger, and it's there regardless of your cycle, then that's not normal. Having bloody or clear nipple discharge that comes out of one breast and one little duct orifice can be a sign of breast cancer as well, all right? And when that happens, there's some special procedures that we can do. Now, I know that doesn't look very comfortable either, but we do put some topical anesthetic gel on the nipple, and we use a very tiny little catheter that has a little hook in it, and we kind of just trace it on the surface of the nipple, and it'll fall right into that duct that the discharge is coming from. And we secure it with a little steri-strip and just slowly inject a little bit of contrast dye, and it'll fill that whole ductal system, okay? And we look for an area where it's not filling, what we call a filling defect, because that's a little mass growing in that ductal system, and that's worrisome. And now we can direct the surgeon of where they need to do that biopsy. Okay? So what are the different procedures that we do with mammography? We do something called a stereotactic core biopsy, and I'm going to go over that in more detail, and we do wire localized surgical excisional biopsies. So again, let's talk about some terminology. Merriam-Webster defines biopsy as the removal and examination of cells, fluid, or tissue from the living body. For in mammography, the different types of biopsies we will perform is a fine needle aspiration. It's a really skinny little needle. It's less than 22 gauge. It's very, very small. And we typically will just remove some fluid, maybe from a cyst, or just a few cells that they'll look under a microscope. A core biopsy uses a larger needle, and now we're actually taking out small pieces of tissue that might be the size of angel hair pasta, okay? Whereas a surgical excisional biopsy, that they're taking that out with a knife, okay? The patient's going to the operating room and a surgeon is making an incision and they're actually removing the whole lesion, all right? Now, when we use the word lumpectomy, a lot of women get confused and they think, well, I had a lump and it came out, so that's a lumpectomy. But really, we reserve that term for breast cancer, okay? And if you say you've had a lumpectomy, you've had breast cancer that's been removed. Otherwise, if it was benign, we typically call that a benign surgical excisional biopsy. All right, so stereotactic core biopsies, we'll perform those when we only see something on the mammogram, right? You can't feel it, so there's no other way for them to sample it, and it looks worrisome to us. So we have to find out what it is. It can be done with either the patient lying on a table, and there's a little hole in the table that their breast will fall through. I don't know if you can see there that her breast is through that little hole, and we'll compress it just like we do with mammography, or they can be sitting upright. Some of the equipment we have, the patient can actually sit upright, and again, they have to be in compression to hold that breast still. And then we put some betadine to clean it off, give local anesthesia, make a little incision, and that needle goes right inside. Now, when the big needle goes in, we find our target. So here's a cluster of calcifications that we're going to biopsy. We fire that, and so we see this little trough. That cluster of calcifications is right in that trough. And we push a button, and it rotates around, and there's a vacuum, and it pulls the tissue in, and it cuts it, and pulls the tissue in, and it cuts it. And we go around kind of the face of the clock, and it takes about 12 pieces of tissue for us. Here's the little hole that it left, so our calcifications are gone. And we leave a little marker so we can show where we were, because in the event this turns out to be something pre-invasive or even invasive, they have to know where to go back. This is not therapeutic. This does not cure the disease. It's diagnostic. It makes a diagnosis. Even if we take it all out, they still have to go to surgery for the final treatment, which is taking out and clearing up all the tissue around there, okay? And then we confirm and we x-ray those little pieces of tissue to make sure that we got what we were after, those little calcifications. Okay, this is after her biopsy. Everyone's, well, what about this clip? I don't like the idea of having a clip inside. It's this tiny little thing right there. You can barely see it, that tiny little metallic thing. It's made of titanium. It doesn't go off in the metal detector. Everybody wants to know, I don't want anything in my breast. It doesn't, do any harm, all right? Sometimes they'll migrate a little bit and they'll move position, but you can still have an MRI and all of that. Wire localization. So now let's say we did the biopsy and it turns out to be pre-invasive or invasive disease. And again, they have to go for their actual curative treatment, but they can't feel it. So we have to guide them where to go. Now we do a wire localized procedure. We put them in the compression. There's the little clip from the biopsy before, and we use this grid. And I say, okay, this is going to be about C and 12. And then I put my needle, I'm going in en face, directly on it to make sure I'm right over it. I check in the other plane to make sure my depth is okay. And then I put a hook wire. It's like a little fish hook so that it stays in place. I take the needle out and leave the wire inside, and this is the specimen. That's what that hook wire looks like. So we make sure, and then I'll call the surgeon and go, it's kind of on the edge of the specimen. You need to take a little more tissue around there. And then we just confirm again that the whole wire came out and that we got the target that we were after. Okay, right there. So how does mammography do overall? For the general population, they say the sensitivity is about 85%. Okay, so of 100 cancers, we'll find 85 of them. But that will vary somewhat depending on the breast density. And in dense breasts, it's been reported to be as low as 30 to 40%. All right? Specificity, when it's normal, 97% of the time we'll call it normal. So 3% of the time, we're going to call it back and say that there's something abnormal, and it may not turn out to be anything. Positive predictive value, about a third. So of what we recommend for biopsy, 2/3 of the time it likely comes out benign, and only a third of the time it turns out to be cancer. All right? And we know from many randomized controlled trials looking at different populations where one set of the population got screening mammography and then another set didn't, that over a long period of time that we can reduce mortality or death from breast cancer by about 30%. Okay? And mammography is the only imaging modality out of these three that I talked about that those type of studies have even been done, looking at mortality reduction. Now, so what are the limitations of mammography? Why isn't it perfect? Well, density is a problem, and there's an overlap in appearance of benign and malignant. I mean, I look at two cases that look like an identical cluster of calcifications, and one will be benign and one will be malignant. And I just can't tell the difference. No one can. And that's why we have to biopsy them, and that's why 2/3 come out to be benign and a third turn out to be malignant. It's just the way some cancers are, and it's somewhat subjective. Unfortunately, it's not like a lab value where you just get a number out and it's positive or negative. It's quite subjective. So now, what are your perceptions? This was kind of an interesting study of what does the general public think? How do they think mammography does? 45% of women believe screening mammography finds all cancers, 100% sensitivity. 57% believe that mammography prevents or reduces their risk of cancer. Interesting. 74% believe that finding cancer early saves lives most or all of the time. And 45% say financial compensation should be awarded for a cancer missed by mammography, even if it could not be visualized. So let's look at the facts here. By the Physicians Insurance Association of America's summary, what percent of how is breast cancer first detected? Screening mammography, 15%, guys. All right? Most breast cancer is still detected by the patient, close to 60%. Screening mammography only picks up 15% of all cases of breast cancer. Now, how did this happen? We oversold the public. We did great marketing. You have to have your mammogram every year. It's so important, right? And so that's what's created this. Now they think that it's the woman's panacea to all ills, right, is getting your mammogram. But that's part of the reason, and there's many others, why delay of diagnosis in breast cancer continues to be the leading cause of malpractice suits, and radiologists are more frequently named than any other defendant. Okay? So, in summary, it's not a perfect test, particularly in women with dense breasts. We could use some help. We could use some other ways that we can image the breast. But it's the only technique to date that has shown that it can reduce death due to breast cancer. And since the onset of mammography screening, the death rate from breast cancer has decreased since 1990 by 30%, whereas in the preceding 50 years prior to that, there was no change in mortality. Now, that varies a little bit by the age of the woman. The death rate has been decreased by 33% in women over the age of 50 and only 18% in younger women. All right, and there are some reasons for that, and we're going to talk about that a little bit later, but that's important. So what about ultrasound? How does that work? This is an ultrasound machine. It's kind of a big unit, but this little guy right here, this transducer or probe, is where all the money is. Inside that little probe, there's crystals, and they vibrate, and they send out sound waves. And the way that those sound waves interact with the breast tissue, how it changes that sound wave when it comes back is what creates the images. So there's no x-rays. That's kind of nice. And then the image is displayed on a monitor over here. We typically ask the patient to lie with one arm behind their head, so it kind of splays out the breast tissue. We use some warm gel to be kind, because having some liquid helps those sound waves travel through the breast better. So it's just some gentle pressure with the probe. It'll take anywhere from 2 to 10 minutes. It depends what we're looking for or how much of the breast we have to look at. And these are what the images look like. This is a fatty breast over here. These are fat lobules. They're kind of dark, just like on mammography. The fat was dark. And in the dense breasts, the fibroductal tissue is white. So that's the same as mammography too. However, what's different is that cancer on ultrasound is dark. So now we get to see that in the dense breasts. It's the perfect complement to mammography. Whereas cancer was white on mammography, and so it was hard to see in a dense breast. Cancer is dark on ultrasound, so we can see it in a dense breast. Here's some ultrasound images. These are little clip stores as I'm scanning through the breast. This was a benign fibroadenoma, and there's a little black dot right there. That's a cyst. This is a cancer, an invasive cancer. And as I'm going through it, you can kind of appreciate those little terminal ductal lobular units that are involved, just like we saw on that diagram of the breast. That's what a breast cancer will look like. So what do we look for? Focal dark areas, they're masses. We look for different things about that mass. Does it have color? And I'm going to talk about that in a second. What is its shape? What does it do to the sound wave behind it? All of those things are going to help me differentiate it. Is it a cyst and just filled with fluid, or is it something solid? And if it's solid, is it something benign that I can just watch, or do I have to stick a needle in it, and does it look malignant? And then I can look in the lymph nodes. I can look up in the axilla too and see if they're involved. We call that lymphadenopathy, when there's pathologic nodes. So what about this color? What does that mean? Well, this is actually a technique that was developed by a guy by the last name of Doppler, who figured out that when things were moving on the ultrasound, he could make color appear on the image. And we know that blood cells move in vessels, and we know that vessels are in solid things and not cysts. So if we have an image like this, and there's this kind of dark gray lesion, it's got irregular margins, and we put color on it, by seeing all this color flow in there, it tells us it has blood flow in it. So it's not a cyst and it's something solid. Seeing the blood flow helps confirm it's solid. Not seeing blood flow and other things confirm that it's a cyst, and we don't have to worry about it. So it's both, if it's present or absent, gives a lot of value. So if you're having ultrasound and you see all this color going on the screen, that's what we're looking for. We're looking to see if there's blood flow in it. Another thing we can do, because sometimes cancers can be really hard to see in fatty breasts because they're both dark, is we might ask you to hum or go ee, because normal tissue will vibrate. And when we put this special form of Doppler on there, if it's a fat lobule, everything will vibrate. But if there's a cancer in there, that one area isn't going to vibrate because it's stiffer. So that's how we can use color too. Here's some examples of all benign things. This is a cyst. It's black because they're fluid. The sound wave travels easy through there. It causes a brightness behind it. This is a sebaceous cyst, those little things that you can get in the skin that can form little boils and stuff. Sometimes those cause masses, and people worry about them, and we'll do an ultrasound and show, oh, it's just in the skin, and it's a sebaceous cyst. This is something called a fibroadenoma. It's the most common solid mass, particularly in a young woman. It's benign, has smooth margins. It'll have flow because it is solid, but it's benign. We may watch those, we may biopsy them to prove that they're benign, and these are all cancers. They look a little different, huh? They cause this shadowing. They're very irregular, spiculated. Some will have color, sometimes they won't. But I don't need the color to tell me that this looks bad, right? They look very different. We can look at the lymph nodes. Lymph nodes look like little kidney beans. They have this little kidney bean shape to them. And when they start having kind of these globular areas that look thick and dark, or we don't see any of the fat, they're just big and round, that's abnormal, and we can biopsy them and prove it. So how do we use ultrasound? Well, for the most part, we use it as a diagnostic exam, all right? And I'm going to talk about different uses. We can help us guide procedures, and then sometimes we can use it as a screening exam, but that's not the primary role of ultrasound compared to mammography. So for the diagnostic breast ultrasound, that's going to be, we're looking at a very specific area where the patient has a problem, where she's feeling something, where the doctor's feeling something, where we saw something on the mammogram. We call it a targeted breast ultrasound because we're only looking in that one area. And it's considered to be, again, in conjunction with mammography. And again, we can do this at any age, any gender, any time. In fact, if a woman is under the age of 30, we'll often start with the ultrasound, because it's more likely she's going to have benign disease. It's more likely she's going to have a dense breast, and it's going to be harder for me to see something, and I don't want to expose her to radiation. So under the age of 30, if a woman comes in with a lump, I'm going to start with the ultrasound. Or if she's lactating or pregnant, kind of the same reasons. So how do we use it? Something on mammography. These are two different patients that I'm putting side by side. They both have these white masses, right? But they look the same on ultrasound. This one tells me it's a cyst. This is a phylloides tumor, okay? But on mammography, I can't tell the difference. They just both look white. So ultrasound helps tell me if it's got fluid in it, it's a cyst, or if it's something solid. Here's a woman that had a lump that she felt. pretty dense breasts. I can't see anything there. This little BB here, we'll put a BB on the skin, and it's radio opaque, meaning it shows up as a white dot so that I know exactly where to focus my attention, where you're feeling something. I don't see anything there. And on ultrasound, there was an invasive ductal carcinoma. Okay, so whenever anybody comes in with anything palpable, we do the ultrasound as well. These are what implants look like on ultrasound. Sometimes we're asked to look at implants under ultrasound. Whether they're saline or silicone, they look the same. They're both just dark, they're fluid. This woman felt that her left breast was getting bigger, and we can kind of see this one's more relaxed and this one's more taut. That's because, again, it was developing that capsular contracture. Your body recognizes it as a foreign body. It says, you're not supposed to be here. And it tries to reject it, and it sends up all this scar tissue around it. And so it can make it sometimes feel larger, and it's just because it's being compressed. All right. And this woman was lactating. She was breastfeeding, and she had an infection. And it wasn't going away with antibiotics. She had some focal pain and redness. And so we were asked to do an ultrasound. And what I'm going to show you here, there's just a bunch of dark stuff. But right here, do you see all these little things moving? And I'm pushing on it here, and I see all these little echoes moving. That's pus moving around. This was an abscess. Okay, so ultrasound can be used to determine whether or not it's just an infection of the skin and the tissues, or whether there's actual a collection of pus in there that needs to be drained. We often use ultrasound to evaluate how extensive is the disease. This is a woman that came to me with a known cancer. The doctor felt something, they put a needle in it, they got ductal carcinoma. So they sent her to me, and which is not uncommon, so we could see how extensive is this disease, and is there anything in the other breast. And I saw this irregular mass on the mammogram, and we saw the corresponding dark, shadowing, irregular-looking mass on ultrasound. But look what else we saw. There wasn't just that one. There was 2, 3, 4, 5. There were 4 little satellite lesions that were going along a ductal pattern that we couldn't appreciate either clinically by palpation or on the mammogram. So now I could tell them, no, we're not just dealing with a 2-centimeter cancer, we're dealing with 6 centimeters of disease. Okay, changes her stage, changes the surgical treatment and planning, and I can tell them how far away it is from the nipple. Because if it gets too close to the nipple and you can't spare the nipple, they often will just recommend a mastectomy. We looked in her axilla as well, and this lymph node looked abnormal, and we were able to biopsy it and show that she already had spread to her lymph nodes. What about guiding for procedures? Ultrasound is really, really helpful, because if there is this lesion in the breast and we put the probe down, the direction of the ultrasound beams coming down is a perfect setup for us to see that. Very, very nice. This white line here is the needle within the lesion. Again, we can do that fine needle aspiration, where we're just moving the needle back and forth, obtaining cells that we put on a microscope for the cytologist to look at. Or right here, do you see how I'm just aspirating and this mass is shrinking? That's because I'm taking the fluid out. It turned out to just be a cyst. It didn't look like that, or we would have left it alone, but it looked like maybe it wasn't. And so once we aspirate, we just took the cells out. And the good thing about this is often your pathologist or cytologist is right in the room, and we can give you an answer immediately. It'll be preliminary. It'll still take 5 to 7 days to get the final result, but they can give us an answer right away. Whereas a core biopsy, now that's a little bit more invasive. We'll make a little incision. It's a bigger kind of core biopsy gun, we call it. And here's an example of that going through there. We'll often have to take multiple passes through that. There's certain types of biopsy guns where it just goes in one time. So here was a lesion, and here's the gun through it. And when I play this little movie, now watch and see, that's going to open, and it's got a vacuum, and it sucks the tissue down into it and cuts it. And then all I have to do is turn it around, and it keeps sucking tissue in and cutting it. And again, we get those little kind of angel hair-sized pasta pieces of tissue. And then to prove where we were, I'm going to show you this. We're going to deploy a little clip. Boom. You see that? That little white thing. It has certain material on it that we can see very well with ultrasound to show that we were, where we had done the biopsy, because we might remove the whole thing. We can also localize things, again, for them to take out at the time of surgery. It's more comfortable for the patient if we can do it this way. So if a mass or a lesion is seen both on mammography and ultrasound, I'll often prefer to localize it via ultrasound, because again, it's just more comfortable for the patient. There's the little wire going in. It's very, very skinny, so it's harder to see. But here this confirms, again, that was that same woman that had that cancer that looked like a sunburst. and the wire's intact, and she actually had a positive node that was draining to the skin, and so they were able to take all of that out because they couldn't feel that lesion. It was so deep, and she had such a large fatty breast. So screening breast ultrasound now is a little bit of a different bird, because remember, with screening, they can't have any symptoms. It's not that we saw anything on the mammogram. And now they do it on, typically they'll do it on both breasts, and it's called whole breast ultrasound screening, or whole breast screening ultrasound, okay? It's typically done as well as with a screening mammogram, but typically only in patients that have very dense breasts, right? Because they found if you have a fatty breast, mammography is fine, it does well enough. And it's in those fatty breasts where ultrasound doesn't do as well, right? So it's not a good complementary technique. So typically we'll only do whole breast screening if you have dense breasts. Now, lots of studies have been done and show that if you do screening ultrasound of both whole breasts, in addition to screening mammography, they will find 3 to 4 more cancers per 1,000 patients that they do it on. That's pretty good, huh? In fact, the mammographic accuracy in this one, from this one large study that had close to 50,000 patients, found that mammography found 78%. If they did ultrasound alone, they only found 50, but together it was up to 91. So now using them together, that's pretty good. We're finding a lot more cancers. The problem is it finds a lot more of everything, and you don't know what it is, so it causes more biopsies. So again, talking about that positive predictive value, when they were looking at how many times they recommended biopsy by doing this whole breast screening, it was only 11% of the time it turned out to be cancer versus the 33%. So we're going to do a lot more biopsies that don't really need to be done. And so it's always a cost-benefit, kind of ratio of, you think about per that individual woman, it might mean everything, right? But is it worthwhile to do on everybody and do all of these extra biopsies that don't pick up a lot of disease? And there have not been any studies yet that have shown by doing whole breast screening ultrasound that we're going to decrease the death rate from breast cancer. Those studies just haven't been done. So in summary, for problem solving, it's wonderful. I can't imagine not having ultrasound. I use it all the time. We got to give it points for not having radiation, right? That's a really good thing. As a screening exam, though, it's even less perfect of an exam than mammography, and we can only use it in dense breasts because that is where we see the increase in cancer detection, and we can consider it. But again, we haven't shown that we can reduce mortality, which is death. What about breast MRI? That's our third modality. This uses magnetic waves, and so this is a big magnet, an MRI. The patient lies on her belly, and there are this coil here, which is like a plate that has an opening in it. And again, the breast hangs through there. We'll typically do both breasts. We'll slide the patient, and the magnetic force comes from big magnets within this portion here, okay? The patient kind of gets slid into this machine, and we usually go feet first, so even if you're claustrophobic, the head is somewhat at least facing out of that little hole. Notice there's an IV pole here because this is the only modality that requires an injection, all right? That's the only way that MRI works, is by looking to see what takes up that contrast. So this does require an injection. It takes 40 to 60 minutes. If you've ever been in a magnet, it makes a lot of loud, kind of irritating noises. You can put earplugs in, you can ask for a headphone, but again, and probably the big contraindications would be claustrophobia, and you have to have good renal function. If you have really bad kidney disease, this contrast that we give can cause complications. So we check everybody what their renal function is with a lab test to make sure that their kidneys are working okay before we even give that contrast. And these are what MRI images look like, and I'm showing you pre- and post-contrast because it's only on these post-contrast, so that's after the contrast is given, that you see those white areas. That's where the contrast is being taken up. These are implants. These are saline implants. They look dark because this is water suppressed. So there's a way that we can say, take out all the water, and right here there's enhancement in this ductal distribution that it was very difficult to read her mammogram because of these implants. So again, what do we look for? We look for these areas that take up the contrast, so they're going to be white. They can be tiny dots, they can be linear or clumped. We look for the enhancement pattern. How does it take up that contrast? How does the contrast wash out of the lesion? And we look for associated changes. Now, the one on here that I want to point out because it's important is it's the only modality we've talked about that it can actually assess whether or not it's invaded into the muscle or the chest wall, because it has this big field of view. We can't really evaluate that with either a mammogram or an ultrasound, but we can see if it's invaded into the chest wall with an MRI. These are these kinetic curves that I was talking about. We look to see two different phases. In the beginning, does it take it up slow, medium, or rapid? And then what does it do after a little bit of time? After a couple minutes, does it continue to rise? Does it wash out? And then we know that the slow and persistent ones are typically good things, and cancers have a rapid uptake of the contrast, but it also washes them out really quickly as well. So again, we use them the same ways. Number one, for diagnostic purposes. There are some women that will do it as a screening exam, so again, no symptoms. And then we use it, we can guide for procedures as well. So problem solving is really the big indication for MRI. We evaluate extent of disease. So particularly if a woman has known cancer, it's been proven, but she's got a dense breast and it's hard for us to see what else is going on, we'll often get an MRI. Particularly as sometimes patients present and they already have spread to the lymph nodes, either in their armpit or along their neck, and they have no idea where the cancer is coming from. They just know it's some sort of adenocarcinoma. That's a good indication for, if it's a woman, to do a breast MRI and see if the primary is coming from the breast. Evaluating response to therapy. How is that tumor responding to chemotherapy? We can assess how it changes, how it's taking up that contrast to determine whether or not it's responding to the chemotherapy, whether or not we need to change the chemotherapy somewhere mid-course. So here's an example. This woman had a left DCIS. It was just pre-invasive disease. I'm showing you her right mammogram because she's very dense and we didn't see anything there. And now I'm going to show you this little movie that's going to come up. And I'm going to show you the initial, so it's the pre-contrast, and it's going to be followed by right after the contrast and a little delay. So the patient's upside, she's lying down, so the breasts are kind of pendulous. And this is the right breast we're going to focus on. We're about to see the contrast, and I want you to pay attention right in this area. It's coming, and boom. Did you see that little white bright dot? Just flew by you like that. We're going to get one more chance at it. This is the delayed. And look right in that area. And boom, that little white dot. That was it. That, my friends, is a little invasive carcinoma that we could not see. And look, see how beautifully we see it, even though she has very dense breasts. This is called a MIP image, a multiple intensity projection that has almost a 3D type of appearance that can help sometimes the surgeon kind of gauge, or even the patient, what this is looking like in the breast. Extent of disease. This was a 34-year-old woman who had multiple masses in her breast. She had a biopsy at an outside institution that showed she had a fibroadenoma. Now she was feeling multiple new things, so we have these BBs on her. But there was an area here of architectural distortion, right? It looks pulled, it looks retracted. We got some extra views. These are spot compression views. So typically we use that big paddle to compress, but if we use a smaller paddle, we can spread out the overlapping stuff even more and get a better idea of what's going on. So that's what we're seeing here. There's the ultrasound. You guys are experts by now. You know dark and shadowing is bad. And when we biopsy it, this was an infiltrating ductal carcinoma. But she had all these other masses. We're like, oh my gosh, what else is going on in her? So we put her in the magnet. Whoa. She had more than a dozen other lesions in both breasts, okay, that we could not see. More problem solving. This woman had a mammogram. She had a strong family history of breast cancer, both her mother and sister. On the outside, she had a biopsy of this kind of dense area, right? It's looking white, it looks irregular, and it came back benign. I was like, ooh, I don't know if I believe that. It looks pretty bad. So we put her in the magnet, and this is what it looks like in multiple planes. We can reconstruct that in the sagittal plane and the coronal plane. This little dark spot here is the clip. So the clip has this susceptibility artifact that just looks black. It doesn't give any signal back. And nothing enhanced, which was great news. That fit with the benign biopsy. And so even though it looked a little suspicious, and then more we questioned her, she had some trauma a long time ago. She fell down a flight of stairs. She had all right-sided trauma. Didn't really have a mammogram for this, we didn't know, and it was probably where she had a bunch of scarring from her trauma. These are implants, okay? And these are silicone. They're very, very white. They're behind the muscle, and there was an area over here. We were questioning whether or not she had extravasation of her silicone. So we did a MRI. The white stuff is the silicone, and it was really just a contracture. This is just the envelope of the implant was all folded on itself, okay, and there was not extravasation. But for screening again, remember, this is not problem solving. This would be just that they're at high risk and they have no symptoms, and all the other imaging modalities we use have been normal. So typically this is going to be performed on both breasts, and again, it's going to be in conjunction with the screening mammogram, whether or not they have dense breasts or not. We're going to talk about that. This was a young woman. She was 28. She had a prior benign biopsy. She had a very strong family history. One of her family members had tested positive for a gene that carries a very high risk for breast cancer. Didn't see a whole lot on her mammogram because she was very dense. This is her MRI. This is something called a subtracted image after the contrast, where everything that was there before the contrast gets subtracted out, and the only thing we see is what's enhancing with the contrast. Look at the size of that thing that we couldn't see at all with the mammogram. We can put a computer-aided detected system on this. It shows red where there's an abnormal pattern of uptake, and then here's that curve, rapid uptake, rapid washout, right? And this was an invasive ductal carcinoma. This is again, these MIP images I talked about, you can rotate them around and show what it looks like in both breasts. Again, it's sometimes helpful to the surgeon to kind of get an idea of what's going on. Now, reviewing many studies that have shown doing the supplemental screening in these high-risk patients and combining them all, because again, we don't have a ton of data out there. This is relatively new. But looking at all the data we have and combining it, we've got about results from about 4,500 women. We find that the sensitivity in this group, and again, they're going to be high risk and very dense, was only 36% on mammography. By doing the MRI, 81%, and combining them, 93%. That's really pretty good, huh? So we find that MRI detects about twice as many cancers in dense breasts, but again, it finds a lot of other things. Everything it finds is not cancer. The positive predictive value is 40%. So now 40% of the time we recommend a biopsy, it's going to be cancer. 60% it's not. So though it picks up a lot of things, it's very, very sensitive, it's still going to pick up some things that are benign. They say about 2 times the number of unneeded additional examinations and 3 times as many unneeded biopsies. Limitations, there's a lot of false positives, not as high as ultrasound. It costs a lot, and it's not accessible to all women. We can do biopsies with MRI. Sometimes we use a grid to localize where it is, or we can do freehand. This is what they use down at Stanford. They have an open magnet where they can do it freehand, and it's the same system with the vacuum that we pull the little pieces of tissue down. So there is the lesion, we're putting the needle in it, and that's what the little specimens look like. But we don't need to x-ray them because we didn't see it. It's only going to be done by MRI when that's the only way that you could find the lesion. So in summary, in the diagnostic setting, it's very sensitive. There's lots of reasons why we can use MRI. That's very, very good. There's some controversy about whether or not it helps to find all these additional sites. Right now, they're saying, well, at least in the limited amount of time that we've been doing this, we haven't been changing the outcomes, the long-term outcomes. So there's some concern that maybe if we didn't know about those extra little lesions, the woman's going to get her lumpectomy, she's going to get radiation to the whole breast anyway. Maybe that radiation was going to take care of those extra little things. And now that we're finding all these extra things, maybe we're sending her to mastectomy too many times when she didn't need it. I don't know the answer. I'm just saying that's what the debate is about right now. And there's a lot of talk about what we're doing here. As a screening exam, it does increase cancer detection in high women, but there's a cost at that. And again, no studies have shown it decreases the death rate. So there's a lot of alternative breast imaging techniques out there that are functional based that you might have heard of. Right now, none of them are used for screening. We just use those 3. So who and when? Now we get to the controversy. Again, for diagnostic, for all these different techniques, I said it could be any gender, any age, any time. It's for the screening exam where the controversy lies. It's going to be the who. It's going to be those that are at greatest risk for developing breast cancer. When, we need to talk about when to start, when to stop, and then how often to get the exam. Who do we screen? Let's look at the breast cancer risk factors, right? Who's at highest risk for developing breast cancer? There's these different types of risk factors. Gender, we know female over male. Okay, it's going to happen in women, typically older women. There's certain races that are more affected, white, African American, and Hawaiian descent. Hormonal factors, the unopposed estrogen theory. So the earlier you got your period, the later you get menopause. If you haven't had children, all of those reasons, having too much estrogen around places you at slightly increased risk. If you have denser breasts, they thought at first that maybe we just didn't see them as well, but now that's kind of, they're thinking again, if you actually have denser breasts or if your breast density gets denser over time, that's actually a risk factor for developing breast cancer. Many lifestyle risk factors that are not uncommon to increasing risk of other types of cancers as well: obesity, lifestyle, exposures, prior chest irradiation, family history, personal history of different types of cancers, and then there's some genetic mutations. So out of all of these, though, the two highest risk factors are being female and older, okay? Which is why many societies, and I've listed them here, recommend screening mammography in women beginning at age 40 annually every 1 to 2 years. But why 40? Well, let's start with it's relatively arbitrary. There's nothing magical about turning 40 and then all of a sudden you're at risk for breast cancer when before you weren't. It's based on balancing the likelihood of developing breast cancer, detecting it, and inducing breast cancer, right? And then you estimate the benefits and the risks of the procedure. So let's look at the incidence of breast cancer. The median age, the average age is 61. The peak age is between 75 and 79, and then after 80, it somewhat declines. If we want to capture 77% of all breast cancer, we'd have to start at 55. But if we wanted to capture 95% of the breast cancer, we'd have to start at 40, okay? What about mammography sensitivity? So again, the likelihood that the exam, mammograms, are going to pick up the disease. Well, we know that breast density and sensitivity are inversely related, right? In those fatty breasts, we pick up disease a lot of the time. It's easy to see. But in those dense breasts, it can be quite low. They've actually shown that mammograms are better both for sensitivity and the positive predictive value with increasing age, likely because there's fatty involution and you tend to get fattier over time. What about inducing breast cancer? Now, there's a lot we know and there's a lot we don't know, and a lot is speculative. We know that young breasts are one of the most sensitive tissues to ionizing radiation, and it has a lot to do with estrogen. When you have estrogen around, it makes those breast cells even more sensitive to radiation. We know that there's increased breast cancer rates seen in atomic bomb survivors, patients who have been treated for Hodgkin's disease, treated with medical x-rays, excessive medical x-rays for TB and scoliosis in the past. And we know that the younger the age of exposure, the longer the latency. So the longer it's going to take for that breast cancer to actually develop. But we don't know how young is too young, how low is low enough, and is there a safe dose? There's a presumed linear relationship that no dose is safe. And the more you get over time, it's going to increase your risk. But again, that's not proven. It's just a theory. So if we get one mammogram exam, that's about 0.3 centigrade. That's about the equivalent of 3 months of background radiation, okay, just to put it in perspective. After about 10 annual mammograms, that's going to be 3. And based on studies, because there haven't been any, we can't really do a study saying we're going to irradiate all these people and not these and see who develops cancer. No one's going to prove that. We can't do such a study. But if we just kind of extrapolate from what we do know with really high doses, what that risk is, the relative risk only increases about 1.01 after 10 years. So an average risk woman has about a 12% lifetime risk of developing breast cancer, all right? If she gets 10 mammograms over 10 years, so 1 a year, that increases to 12.1%. Okay, again, this is theoretical. There's been no statistically significant increase in detected dose below 20. While the risk is very small, again, we want to minimize it as much as possible. So 40 seems to be about the right age, below which cancer is not that likely. It's pretty rare. It's going to be harder for us to see, and there's some risk, possible risk, that we may cause some harm. And about over 40, it's more likely to occur. It's more likely we're going to find it, and it's less likely to cause any harm. So that's just kind of the age that most of these societies are recommending. What about an upper age limit? Now, most of these societies do not impose an upper age limit. They recommend individualizing it per patient and considering stopping when the woman has about 5 to 7 years left of life, because that's about how long it takes before we see a benefit of screening mammography. And so you have to take each person individually. If this woman has a lot of other medical diseases that she's more likely to die from, there's really no point in screening. But, 75 is not 75 is not 75, right? So should we ever screen below the age of 40? And the answer is probably. There are some conditions that place a woman at higher risk for developing breast cancer at a younger age than a woman with no risk factors at age 40. And in those patients, we might want to start sooner. And those are specifically the ones with genetic mutations, family histories, and have had a lot of chest radiation. But again, note, all these studies that showed a reduction in mortality were done in the general population. They did not stratify it by who's at high risk, who's not. So there's a whole bunch of genetic mutations that place a patient at risk for developing breast cancer. I'm just going to focus on something called BRCA1 and BRCA2. Again, you might have heard these terms. They stand for the breast cancer early onset gene 1 and 2. And what they are, they're specific genes that repair DNA damage. And these women have mutations in these genes, so they can't repair the damage. All right, that's how that is. They get a lot of different types of cancers, not just breast cancer. They're at risk for developing a lot of different types of cancer, but specifically breast cancer. Now, it only counts for about 5 to 10% of all breast cancer cases. It exists in way less than 1% of the population, but women of Ashkenazi Jewish descent tend to have it more commonly. In women that have this carrier, the risk for developing breast cancer is towards 85% in their lifetime. So very, very high. Specifically with the BRCA1, they'll tend to get it a little bit earlier than the BRCA2s. But when they've done screening on these women, they found that only half of their cancers were seen at screening. About half of them presented in between what we call interval cancers, in between the 1-year period of getting their mammogram, and they had a greater likelihood of being grade 3 invasive or the triple negative. So again, there's some controversy about, even with aggressive screening, are we going to change the outcomes in these women, or are these just bad acting cancers? What we do know is that mammography alone probably isn't good enough. And this is where we may want to consider screening with MRI. And the American Cancer Society in 2007 recommended that in these patients that they may want to consider annual MRI screening in addition to screening mammography. And it can be done at the same time, or it can be done breaking it up at 6-month intervals, again, to try to catch those interval cancers. So let's just talk about terminology for a second. When we talk about family history, because I mentioned first-degree relatives all the time. What does that mean? If this is the patient, a first-degree relative would be the parents, siblings, and offspring, okay? So second-degree relatives only carry 25% of the genetic mutations, so the aunts, the cousins, the nieces, the nephews, all right? So what's considered significant? You are the untested first-degree relative of a known mutation carrier, okay? So your sister has tested positive for the gene, then you are considered, that is considered significant, okay? If you have more than 2 relatives that are diagnosed with early breast cancer on the same side of the family, having breast and ovarian cancer in your family, having more than 3 relatives with breast cancer, or one that's diagnosed very early under the age of 35, and having male breast cancer in your family is considered significant. Now, again, if you're of Ashkenazi Jewish descent, you don't need as many family members to be involved to be considered at risk, because being of that lineage, you're considered at high risk enough. So these are the people we would consider testing. If you have relatives that fall into this category, there's only one lab right now in Utah that has a patent to this test. It's $3,000. It's a lot of money. And so they've developed some calculators, some risk calculators, mathematical models that will do a pretty good job at determining whether or not you might have this without actually having to go and get the blood tests and pay that kind of money. And these are the different ones that exist. So I'm going to mention the Gale model because that's the most commonly used. And if you go, which I did, to www.cancer.gov, which is by the National Cancer Institute, you will see this cancer risk assessment tool. And you click on the little risk calculator and you get this series of questions, and they ask about your family history and when you got your period and your first live birth. So I went ahead and filled it out for myself just to see. And then I get my 5-year risk and my lifetime risk, and I found that compared to the average age woman, my risk is actually a little bit lower. But the thing is, it only uses first-degree relatives. It doesn't count any of those second-degree relatives. It doesn't count ovarian cancer, okay? The Klaus model is okay, but again, it doesn't predict mutation risk. Only these 3 actually give you that mutation risk and have online calculators, and I've just given you the references if you want to refer to those at a later time. And they typically will rate you as being average risk. This is lifetime risk of developing breast cancer. Less than 15% is considered average, general population. 15 to 20 is kind of intermediate, and then being high risk is more than a 20% lifetime risk of developing breast cancer. And different models will have different results, but you're supposed to use the highest one, and often a professional genetics counselor is a good thing to help you sort through all of these things. Now, prior chest radiation, particularly, again, they were treated for Hodgkin's between the ages of 10 and 30, because they're very young, they're considered at very high risk of developing breast cancer. So in those, particularly that would begin about 8 years after treatment and then peaks about 15 years after. So we may want to screen earlier. Now the newer types of radiation therapy that we're giving have reduced fields, and but there haven't been any studies to really show at this point that that is quite safe. So frequency, meaning how often are we supposed to get a screening mammogram? Some say annually, some say every 1 to 2 years, all right? So in summary, the who, how, and when. If you're of average risk general population, less than 15%, if you're 40 or above, mammograms either every year or every 1 to 2 years is recommended by most, okay? Not all, but most societies. You can consider digital if you are under 50, pre or perimenopausal, and have dense breasts, all right? But if it's available. Now, if you go to a facility and they don't have digital available, that's okay. I mean, analog screen film mammography is just as sensitive, okay? Supplemental screening with ultrasound or MRI is not recommended in the general public, all right? And we should stop when you have less than 5 to 7 years or multiple comorbidities. Intermediate risk, it's pretty much the same thing. Equal to or over 40 annually. Some recommend you might want to consider ultrasound, but you need to be counseled on the risks, that they might find a lot of things that are going to require biopsy that may not turn out to be anything, and MRI is not recommended. Now, in the high-risk women, the ones with the greater than 20% lifetime risk, they recommend annual MRI and mammography, and it depends on when we start, depending on what makes you at that high increased risk. If it's a family history, then they recommend starting 10 years before the age of the youngest relative was diagnosed, but not before age 30. So, mom was diagnosed at 43, you should start at 33. If mom was diagnosed at 35, you're really not going to start at 25. That's just too young. We don't know if that's safe, okay? So we're going to start at 30. That's how that works. But if you're a BRCA carrier, because they're at so high risk, 85% lifetime risk, this is well above the 20%, right? They usually start by age 30, and they may even want to start at 25. History of chest irradiation between 10 and 30, they recommend starting 8 years after therapy, but not before age 25. And again, supplemental whole breast ultrasound should only be considered if MRI is contraindicated. They're claustrophobic, they have renal disease, there's some metal in the body that would they can't get into a magnet. You might want to consider the ultrasound. Once you're diagnosed with breast cancer or carcinoma in situ or any of the atypical hyperplasias, they usually will do a mammography every year, unless, again, you fall into that high-risk category. Then they're going to follow that kind of protocol and realize that 70 to 80% of breast cancer patients have no significant risk factors at all, all right? It's in the general population. So then the world shook. On November 16th, 2009, the United States Preventive Task Force Services changed their former recommendations, which were established in 2002, at which time they did recommend starting at 40 and doing it every 1 to 2 years. This is an independent government agency. There's 16 primary care physicians and public health officials. None of them are breast specialists. And these were their recommendations. No screening for women 40 to 49. Screening mammography from 50 to 74, so they did put an upper age limit in every 2 years. Insufficient evidence for screening women 75 or older. Insufficient evidence for additional benefits of either screening with digital or MRI instead of screen film mammography. and no teaching of breast self-exams and insufficient evidence for a clinical breast exam. Now, I'm not even going to touch the self-breast exams and the clinical breast exam. I'm just going to talk about the imaging. Let's talk about the women, eliminating it for 40 to 49. They did, to their credit, they did say that that was for the general population. They're not talking about the women that carry the high risk factors, the family history and the BRCA carriers, okay? That was for the general population. They did acknowledge that there is a 15% reduction in mortality in women who are screened between these ages. They know that that exists. They did acknowledge that their mortality rate has been decreasing even more in the women 40 to 49 than the general population, okay? And they attributed it to mammography. With screening, the relative risk for death due to breast cancer is the same for women between 39 and 40 as it is 50 to 59. They have this. I read the whole thing. And they admitted that the 10-year risk for breast cancer is about 1 in 69 for women at 40, and this is for different ages. You can see that's where it falls in. So for a 50-year-old, it's about 1 in 42. For a 40-year-old, it's 1 in 69. However, they stated that you needed to screen about 1,900 women to find one breast cancer. And they thought that was too much compared to you had to screen 1,339 to find one in a woman 50 to 59. They said that if you could start at 50 rather than at 40 and do it every 2 years, they'd still save 80% of the women they would be screening by doing them anyway. And you'd only sacrifice 33 years of life per 1,000 women. You'd only lose 3% of the actual number of women that would die from this, but what they didn't consider, that that's 40% of the years of life saved, because these younger women have more years of life to live. They said they commented on the harms outweigh the benefits. They said there was anxiety over the false positive results, the need for additional testing and biopsy, the possibility of overdiagnosing and overtreatment. I guess they didn't read this study. Researchers out of the UK evaluated the psychological effects of screening mammography in women that were less than 50 with a family history. They measured their level of cancer worry in 2 different groups. Ones that they were all given a result right away, and some were cleared right away, and then others had to be called back for additional tests. And then they were given an all clear result. And what they found is it was those recalled women, actually, though they were slightly more stressed temporarily, their overall experience about mammography was more positive about the benefits of screening than those that weren't even called back the first time. And then in their guidelines, they said the anxiety, distress, and other psychosocial effects can exist with abnormal mammography, but fortunately are usually transient, and they don't seem to be a barrier. I don't really understand. Overdiagnosis and overtreatment. This one I'll give them. There is a little bit of concern there. We're talking about the ductal carcinoma in situ. Now, mind you, I admit, so we don't know which of these. They're not all going to turn into invasive disease. And they quoted one study. We know that this is something that's really a mammographic diagnosis. The incidence of DCIS, the cases that exist of DCIS, have increased with screening mammography. In 1983, there were 4,900 cases in the United States. In 2009, there were 62,000 cases. It's not that more cancers are occurring, we're just finding more of this DCIS, okay? And it doesn't always progress to invasive disease. They quoted one study where it was fewer than half. So they're saying in these other half that are going on to radical treatments and lumpectomies and all this, that they may not need it. The problem is, we don't know which ones are going to go on to be the bad actors. There's a lot of work going on right now in molecular biology where they'll take the little pieces of tissue and they'll run tests on them to try to determine which ones are going to be the bad actors and which ones we don't have to. But nonetheless, you still have to find it first, and you still have to do the biopsy to send it off to do those tests to figure out what's going to happen. What about the 75 years or older? They made a valid point. All the randomized control trials did not include women over that age group. They just didn't include them. However, there's no reason to think that it wouldn't be as good in the older age population, and several studies have shown that we even pick up more cancers, and the positive predictive value is even better with increasing age. There was one study where they showed a retrospective study of 690,000 women between 66 and 79, and they found that their incidence of metastatic breast cancer was reduced by 43% with screening. And as I said, 75 is not 75 is not 75. Here's the average life expectancy in the United States today. an average, sometimes still has a good 10 to 13 years of life, and maybe it's just not justified to put a universal upper age limit on it. I think we have to take every woman individually into consideration to decide when to stop screening. So in summary, again, kind of my summary, they did not deny that breast cancer occurs in women of these age groups, that it kills women in these age groups, and that switching to biannual screening will sacrifice more lives. They know, and they do not deny that screening, saves lives, but they concluded that in these age groups, it does not save enough lives, that it's not worthwhile, and it's not efficient, was the word that they used. Okay, the only other organization that has supported this is the World Health Organization this past year as well. It has been disavowed by all of these organizations that consist of the breast and medical health specialists, including the Secretary of the Department of Health and Human Services and in congressional legislation when they're talking about health care reform. So in December, a month later, they did revise it a little bit. The decision to start regular biannual screening mammography before the age of 50 should be an individual one and take patient context into account, including the patient's values regarding specific benefits and harms. I don't know what that means, but unfortunately, what's happening is the insurance companies have figured out a way that they don't have to pay for it. The Avon Foundation for Women did this survey the first week in February. We participated in that. It was that they surveyed 151 breast cancer health educators and providers from 48 states, including District of Columbia, and they were trying to figure out what's happened so far since these guidelines have come out. 25% of the states have reported some change in their state screening program for uninsured and underinsured women, finding that fewer mammograms were being done, and some programs were eliminating women under the age of 50 altogether. In California, in our state, on December 2nd, they announced, and it did become effective because this is who I serve at the county, that as of January 1, 2010, the Every Woman Counts program, I like that name, provides breast and cervical screening programs for women who are 200% or below the federal poverty level. They have no insurance or are not covered. They do not qualify for Medi-Cal or any other government program, and they have to live in the state of California, okay? The minimum age for eligibility was raised from 40 to 50 starting January 1, unless they've been previously in the program before and they have an abnormal mammogram and it hasn't been worked up yet. But starting July 1 in 6 months, doesn't matter, 50 it's starting at. And we're not the only state. Now, note just for a little perspective that between the years of 2003 and 2008, 384,000 mammograms were provided through this service. They found 1,500 cases of breast cancer, and 45% were in the age group of 40 to 49. Now, there's been reaction, thank goodness. In San Francisco, Assembly members Noreen Evans and Pedro Nava have introduced a bill that is at least being considered, asking the state to reverse that decision because it's placing uninsured women disproportionately at risk from dying from breast cancer. And it's going to be heard on March 23rd of this year. We'll see what happens. So, reports and regulations. Like I said, there's one word here, Mammography Quality Standards Act. It was introduced in 1992. It became effective on April 29, 1999. Mammography is the only federally regulated imaging modality that we have in radiology. It requires a facility to be certified by the state and the government and have an annual inspection. And the intent was to maintain high quality equipment, high quality images, have good communication. It told us how we should dictate our reports, what we had to say, so that in what we had to do. You are allowed, and you would have to receive a letter in layman's terms with the result and the recommendation of that exam. It's supposed to be within 3 and 5 working days if it's abnormal, and within 30 days if it's a normal result. They've standardized our terminology. There's something called the Breast Imaging Reporting and Data System. It gives us different descriptors that we're supposed to use, so we use all the same language with assessment categories that have numbers. And so we have, if it's an incomplete, that would be something on a screening exam that we say, we don't know yet, we need to do more tests. It can be negative. If we call it benign and give it a 2, because you may see these numbers on your report, we are 100% certain that it is benign. There's no doubt. If we give it a 3, a probably benign, it means it's most definitely benign, but less than 2% likelihood of malignancy, and then we'll just watch it. Whereas the suspicious category is a huge range, 3 to 94% likelihood that it's cancer. If we give it a 5, that is an imaging cancer, 95% likelihood that it's cancer. And if it came to us as a known cancer, they put a needle in it in the doctor's office, then we call it a 6 because we get audited, and if we included all of those cases where we knew it was a cancer and so there was a 5, we'd look really good, right? So they've kind of broken up those 4s if they want to, and all of those numbers come with automatic recommendations. And there was a need for this because prior to this, radiologists were going, well, there's this mass and maybe it's bad and I don't know. You can follow it in 6 months or stick a needle in it, it's up to you. And the primary care providers were like, you're the experts, you need to figure out, tell me what to do with this. So this was a good thing that this happened. This was a really good thing. Now, they also have us do a medical outcomes audit. So for every radiologist who reads mammograms at a certified facility and for the facility in the whole, we have to report how many mammograms we read, what we call each one of those categories, the percent that we call each of those categories, of things that we recommend for biopsy, where we are required to find out the outcome, determine if it's concordant, if it fits, what percent is benign, what percent is malignant, and they give us benchmarks that we have to be operating within this range, which again is a good thing. So we know that people are out there are doing a good job. Now, what are your rights as the consumer? You're allowed a letter in lay terms with the summary of the results. Again, 5 days if normal, 30 if normal. You can get a copy of the official medical report. You just have to ask for it. But you'll get a letter in layman's terms automatically, okay? You're also allowed 1 free copy of your images. So if they try to charge you for it, no, you know better now, right? If you want more than that, you're going to have to pay for it, but you're allowed 1 free copy. And if you're a resident in the state of Connecticut, this is very interesting, effective October 1, 2009, they passed an act requiring that letter to also state your breast density and tell you whether or not you were dense. And you had to include language that said if your mammogram demonstrates that you have dense breasts, which could hide small abnormalities, you might benefit from a supplementary test, which can include a breast ultrasound or breast MRI or both, depending on your risk factors. What I like is they mandated that insurance companies cover it. They have to cover a baseline between 35 and 39, which is even well above what's even being recommended by most societies, annual mammography beginning at age 40, and if you are dense breasts or believed to be high risk, that it will cover an ultrasound, that the insurance will cover it. The Djinni Act is another federal act that was passed that was very important because women were concerned about getting tested. They didn't want to be discriminated against from getting insurance, getting a job if they tested positive with one of these BRCA, being a BRCA carrier and being at such high risk. So in 2008, the Djinni Act, the Genetic Information Non-Discrimination Act, was passed that states that insurance companies and employers cannot require testing, they cannot increase your premiums, they cannot deny coverage due to a pre-existing condition, cannot refuse to hire or fire, and cannot discriminate in terms of salary opportunities, et cetera, and it must become enacted by May of this year, which is a good thing. You also have a right to complain, and every facility has to tell you how to do that. It has to be posted somewhere in the facility that if you have an issue and they cannot resolve it, that you know where you can write a letter to, and that's the accrediting body, and I've listed it here. Now note that there's some things that we have no control over, so think twice before you complain about certain things. In summary here, breast cancer remains prevalent and screening saves lives, okay? We've shown that. None of the current technologies are perfect. They're evolving, they're getting better, we're adding more things. Again, we need those studies to prove how that's gonna affect long-term mortality. Regulations and standardized reporting strive to keep the process safe. And education is important, which all of you know, which is why you're here. I thank you for your attention and welcome you to come by and visit me at the center. I'd love to take you for a tour. Okay, that's it.